A very good morning to you. It is the 27th of May, the year 2014, exactly 4 days remaining before we bring to the end of the month of May. But only 16 days remaining before we take you to Brazil and KBC. We continue to remind you we'll be bringing you live everything as it happens in Brazil. KBC Channel 1 and its radio stations that is will be broadcasting exclusively all those matches, the 64 of them, so you don't want to miss that when the competition gets underway from 12th of next month. 16 days to go, exactly 2 weeks and 2 days remaining before we take you to Brazil. My name is Martin Mwanje. This is Good Morning Kenya, but first things first, we want to talk about matters health, and especially we want to look at hypertension and other non-communicable diseases. And with me in studio is a medical doctor from Netherlands and a senior researcher at African Population and Health Research Center here in Nairobi. That is Stephen van der Vijver. He did say that that name is hard to pronounce, so I'm doing enough to ensure that I get it right. And if you have any question for Mr. van der Vijver, 20511 is the number to SMS. But remember to start with the word GMK. You can as well get us on Facebook and Twitter, and those particular contacts will be scrolling down your screen in a moment. Van der Vijver, I hope I got that name right.
Well, this is very well pronunciated.
Hypertension and other non-communicable diseases. And hypertension, how will you define it?
Hypertension is actually being high blood pressure. And the blood pressure has certain, it's like the pressure you have in your vessels when your heart beats. Mm-hmm. And it has to reach a certain level. But when it reaches above, which is like 140 millimeters mercury, then it becomes high blood pressure or too high or hypertension. And the same is for your lower blood pressure. So hypertension is actually saying your blood pressure is too high.
And what is the recommended level, so that if those levels are at a particular stage, then you devoid of hypertension?
Yeah, well, the preferred level is to have 120 above and 80 diastolic or below. But it can go a bit higher or lower, but to reach the stage when we talk about hypertension, it's above 140 and 90. So when you reach above that, then we talk about hypertension.
Mm-hmm. How prevalent is the situation or the problem of hypertension all over the world?
In general, you can say that roughly 25% of the adult population is suffering from hypertension.
25%?
Yeah, so
that means 1 billion.
1 billion in this planet, yeah. And of this 1 billion, I think it's good to know that the majority is actually in low middle income countries. So 80%, so it's 700-800 million people are suffering from hypertension.
When you talk about the majority being in low income countries, that is developing countries specifically speaking, and therefore the African continent suffers the brunt. Why in low income countries?
It has to do with two elements. I would say it's the globalization or the westernization of lifestyle, mm-hmm. and also a very important topic is the urbanization. Mm-hmm. For example, Africa has always been seen as a rural continent, but whereas the rest of the world already from 2007, 2008, the majority of the people is living in cities. And now Africa is catching up very rapidly. And while people are moving to the cities, they also change their lifestyle and they become at risk of developing an increased blood pressure, hypertension. And they have, for example, there have been studies also here in Kenya about Luos in the 90s who moved from Lake Victoria mm-hmm. to town, to Nairobi, and within 3-4 months their blood pressure went up. So it's really well described, and not just in Kenya settings. I mean, all over the continent and all over the world, you see when people move to cities, mm-hmm. that changes their lifestyle, and they become at risk of developing cardiovascular diseases.
Mm-hmm. So what you're saying is the people who live in rural settings are likely, it is unlikely they're going to suffer from hypertension compared to those who live in urban areas?
Well, it used to be like that, but that's like, now also the rural settings are changing. So, for example, there is a very interesting scientific article also about Kenya, but that's more than 80 years ago, and they said in Africa there's no high blood pressure. But that has changed. While the society is developing, also in the rural setting, there is high blood pressure, there is hypertension, there is cardiovascular diseases. But in general, there's a different form of lifestyle. So where people in the rural settings eat in generally more fruits and vegetables and have in general more physical activity because they work on the land, that changes when they go to urban settings. And generally they get a different diet with more sugar, more salt, more fat, and they have in general also less physical activity. So therefore that increases the risk that they develop cardiovascular disease and that they develop hypertension, which is like a pre-stage.
Let's talk about the causes of hypertension, generally speaking. What will you say, all over the world, what are the key causes of hypertension?
Well, there you can divide it in two groups, which are the causes for hypertension. We say the non-modifiable risk factors. So, for example, age is very important. The older you get, the bigger the risk. But also, for example, genetic factors. African population is more at risk than, for example, European population or the Indian population. And also, genetically and epigenetically, what your past has been. So, for example, when you as a child has been malnourished, the chances are bigger that later in life you develop hypertension and cardiovascular diseases. But genetics and age is hard to influence.
So, in a situation where I'm suffering from hypertension because of my genetic background, do you have a solution for that?
No, not much. Well, I think on a policy level you have solutions, because I think here in Kenya we should try. The level of malnourished children is still very high. So that also creates problems later in life of these kids developing cardiovascular diseases. So it's more on a policy level that we should take care of our children, that they get well fed and well nourished. But on an individual base, once you have reached 40 and you're older and you are genetically prone to hypertension, these are the factors you cannot influence. But there are some other factors which you can influence. And that's, for example, your diet, which is also a risk factor of developing hypertension, smoking, alcohol, to limit the amount of alcohol, physical exercise. So these elements you can do something about.
When you talk about limiting the amount of alcohol, what are we talking about? What is the limit here? Because one will tell you, if I take a bottle, is that a limitation of alcohol?
In general, we say 1 unit. So that's 1 beer or 1 glass of wine. For women, it's 1 unit, and men can have 1 to 2 on a daily basis. But still, what the problem is that you see more and more binge drinking. What means that people sometimes, they don't drink for 2 or 3 days, but then it's weekend, and then Manchester United has won or anything else, and it's party time.
You go for 20.
Exactly, and that's really harming the body. So, but if you have a glass of wine a day, actually, well, research is kind of discussing them, but it's long thought that even a glass of wine a day would actually reduce the risk of getting cardiovascular diseases.
And if there's a possibility, you do away with it altogether?
Yes, well, the thing is, I think to change your lifestyle, you need to have a very structured approach. So changing lifestyle is very difficult. It's difficult in European settings, where I have worked as a medical doctor and had to advise patients. But it's maybe even more difficult in the slums of Nairobi, where we do our research, because people have only a limited budget. And you cannot say, eat an apple a day, go to the gym, because the money is not there. So you have to try to give the advices for lifestyle, to adapt that to the local settings. And there are things that are quite easily to get in your lifestyle. For example, not take the elevator, but take the stairs. Or for example, get off the matatu just one stop earlier and walk the last part. That saves money, and you have physical activity.
And talking about genetics, I'm interested about that genetic factor. Is there a way we can stop, say if I'm a parent and I'm suffering from hypertension, as medical doctors, have you, say, discovered a way you can stop the transmission of myself as a parent, the transfer of a hypertension situation from me to my child?
Well, genetically, it's impossible. But like I said, epigenetically, this is like what influences genes while living, you really can change. So for example, like I said, what is happening when you're a little child is essential. So for example, in Europe, you have all the people who were born in 1944, 1945, they have developed cardiovascular disease in a later stage because they were malnourished when they were kids. So the responsibility you as a parent have, you cannot change the genes of your child, but you can raise your child by giving him a proper diet with lots of fruits and vegetables and play soccer, football in the park. I mean, these kind of things you can do. Because I think living a healthy lifestyle really starts as a young child, and you look to your parents what their example is. So I think there lies the responsibility. You cannot change your genes, but you can change your lifestyle.
And then when you talk about hypertension, are you as medical doctors, have you dichotomized it? Are we talking about we have different types of hypertension, or we just have one type of hypertension, that is hypertension?
Yeah. No, we have two groups, two big groups. It's called primary hypertension or essential hypertension and secondary hypertension. The biggest group of both is the primary or secondary the primary or essential hypertension. It's about 90 to 95% of all cases. And for that, primary means actually there's no reason. It happens because of age, genes, lifestyle. There's not a disease below that. And with primary hypertension, in general, you don't suffer any complaints. You don't have a headache, you don't feel tired, but you live there, you live with a high blood pressure, sometimes for 5 to 10 years, without even noticing it if you don't measure it. Then the other group, the secondary hypertension, that's, like I said, a small group, only 5%. There is most of the times a disease underneath it. So it's sometimes a renal disease, or sometimes there's medication involved. So people use, for example, hormonal contraceptives that can raise the blood pressure. So these are the two groups.
I'm trying to imagine a person who is suffering from hypertension, and this is a person in rural setting, or even here in Nairobi. How do I come to understand that I'm suffering from hypertension? At what point do I start, just trying to sense that something is wrong somewhere?
Yeah, well, I think this is a very critical question, and I think this is also the essential element of really trying to intervene in the hypertension crisis, because, like I said, you don't feel it. And there is a tendency, which is very logical here in Kenya, that you only go to the doctor when you don't feel okay. But I think now with the rise of chronic diseases coming up, I think you really would benefit, specifically if you are above 35 years, to actually go to the doctor, or you don't even have to see a doctor. You can go to a nurse or a pharmacy just to screen yourself and measure your blood pressure. Because it's only when you know your blood pressure, and that's also what the campaign this year is about on the World Hypertension Day, is that you really can do something. Because if you wait for complaints, the risk is that you wait when you reach 50 and you suddenly collapse. And then it's too late, unfortunately.
How frequent do you advise as medical doctors that people go for screening in terms of to establish whether they are suffering from hypertension?
Yeah, well, for me, specifically men, I think when they reach above 35, they should definitely go to a medical doctor or a clinic to have this screening. The good thing is that most of females, they have been in contact with health providers during their pregnancy. And that's also most of the times when their blood pressure is measured. And then when they see it's high, then actually they're followed up also after the pregnancy. But you see that, for example, in a country like Kenya, more than 80% of all people with hypertension are not aware. I mean, that's a
high number.
It's very high, and that came clear from the research APHRC did in Korogocho, Vivandani in Nairobi, but there's also other studies in the country, in the rest of the continent, which have similar outcomes, that just 4 out of 5 people are not aware. So there is the biggest gain to get.
And now that you talk about Kenya, because that's where I wanted to center, and you've been doing research in Kenya for quite some time with the APHRC, and you talk about a study you conducted. How is the situation when you talk about 80%? What will you attribute to that 80% of Kenyans don't understand whether they are suffering from hypertension?
Well, the research APHRC did on these 80% people were not aware was a study done in 2008. That was done through the Wellcome Trust. But based on that, actually, they saw this is a problem. The reason now of the research I'm doing now, the scale-up study, is actually one to develop an intervention to raise awareness, to get people access to screening, get people access to treatment, and then assist them in taking their treatment. Because these are the 4 pillars that are very difficult to maintain. Raise awareness, access to screening, access to treatment, and continue with their medication for the rest of their lives. So what the scale-up study does, and what it has been doing in Korogocho, is that to raise awareness, there was radio jingles on Koch FM. Then there were visits of community health workers. They went to mosques, they went to churches to explain the importance of knowing your blood pressure. And then lastly, community health workers went to all the houses, knocked on the doors, and explained, well, if you are above 35, it would be good to measure your blood pressure. And when you had a blood pressure above this 140 or 90, you got a voucher, and with this voucher, you could get free health care in the clinic that we had trained in Korogocho. We had trained the clinicians and the nurses and give them guidelines on how to treat hypertension. And so when the people came there, they got their medication, and we also assisted them to really continue with their medication by, for example, sending SMS to remind them to come to the clinic and to live a healthy lifestyle. And we also supported them by developing patient groups who would be empowered, for example, by giving cooking classes. So we showed them with Nutrition Without Borders on how to live and eat a healthy diet with a limited budget. So they went actually, I mean, in Korogocho, people have limited budget, but they showed them what is your budget and what do you buy, what can you buy at the market for this amount of money, and then also how do you prepare the food. And then afterwards, the people really could taste and say, well, this is actually quite good, and it's healthy. So you really, like I said, you really have to try to adapt to the local situation in order to assist people to change their lifestyle.
You talk about, you advise that people above 35 should go for screening. Does it mean if I'm below 35 years, I should not go for screening?
No, that's a very good question. I would say in general, if you're an adult, if you are, let's say, 18 years and above, it's just good to know your blood pressure. So everyone is more than welcome to go to the clinic. And for example, also in Korogocho and surroundings in Eastlands, we really want to build it up. And APHRC also organized an event where people could get screened in malls. And I think it's essential that when you measure your blood pressure, also when you're below 35, at least you have a baseline. I'm just saying that the older you get, the higher your risk is. So for example, in Nairobi, I would say people above 35 are just 25% of the population, but they form 75% of the people with hypertension. There's still a group in 18 and 35, and that's why it's good for these people also to measure their blood pressure, but that's more like do it once. If you've never done it, do it. But you should not, or you can, but I would not strongly recommend you do it every year. Whereas if you are 35 years and above, it's good to have a yearly checkup of your blood pressure.
And so in Kenya, generally speaking, because you've worked with the APHRC for quite some time, how many people suffer from hypertension? Do you have statistics in the country? In the country,
yes. Well, like I said, in general, it's about 25% of the population.
That's of 40 million people.
Yeah. So roughly, they have done different studies. Like I said, APHRC has done studies in Korogocho, Vivandani. Other people have done studies in Nakuru. There's been some studies in the West. But they're roughly almost around the same 20-25%. And that's probably going to rise as well. And that's something to do when you see that societies are going to develop, their blood pressure is also going to raise. And you see, for example, a country like South Africa, there the rates of hypertension are much higher. And for example, obesity, in some areas in South Africa, more than half of the women are obese. And you can see that in the last decade, blood pressure and rates of obesity have really gone up, also in Kenya, and specifically in the urban poor.
So obesity is also a key factor, contributing factor to hypertension.
Exactly, yeah. It's one of those, like this range of risk factors. Obesity is definitely also a risk factor. So obesity in itself is a risk factor to develop cardiovascular diseases, but it's also a risk factor to develop hypertension, which in that way can also cause cardiovascular diseases.
The African Population and Health Research Center is, we can say, is mostly focusing on Korogocho. Did you have any reasons that informed that decision of narrowing down to Korogocho and not, say, Kibera?
Well, it's a very good question. Traditionally, APHRC was started as a research center to actually stop the brain drain from African scientists moving outside the continent. And one of the main elements where they started working on was the demographics, actually the high rates of fertility, specifically in the slum settings. And they started in two places, in Korogocho and in Vivandani. And there they decided to follow around 70,000 people. They visit them every 4 months and see if new children were born, if people migrated, people had died. So they have a tradition of following these people, these 70,000 people, for more than 10 years. So that's most of the times their starting base to do their research. So they've nested lots of studies on top of that demographic surveillance side, as they call it. So that's why they focus on Korogocho and Vivandani. But that's more for the research. Now, for the scale-up study, this has proven to be a very interesting model, although the final results still have to come out. But there's now already that other stakeholders, from corporate companies to NGOs, to also the Ministry of Health, have shown interest in this model. So now the idea is to actually implement it to places outside Korogocho. So more people in Nairobi will benefit from this model of prevention and treatment of hypertension. So we're working on that to hopefully in the last few months of this year to really start rolling this out in a bigger area of Nairobi.
And eventually now, because we're talking about county governments in Kenya, do you foresee a situation where your presence is going to be felt in the 47 counties?
Well, I think it's very good to see that the Ministry of Health has a great interest in hypertension and non-communicable diseases. So we have now lots of discussions and meetings, and we have involved the Ministry of Health from the beginning of the development of the scale-up study until the implementation and now the evaluation. They are a very important partner. So they also see the benefits of the scale-up model. So now when we're talking about implementation, they really want to assist us also to implement that in other areas. So we're talking with people in the Ministry of Health at different levels, in the national level, on the county level, to see how this can be implemented in more settings and ideally also in more counties in the country. And I think I'm quite positive that in the next few years that will happen, because policymakers will realize that the big epidemic right now is cardiovascular diseases. And if you don't do anything right now, you create a big problem in 10-15 years.
And now that we're talking about cardiovascular diseases, let's take a short break, but when we come back, we want to talk about those other non-communicable diseases where cardiovascular diseases is among them. This morning, I'm speaking to a medical doctor all the way from Netherlands. He's a senior researcher at African Population and Health Research Center here in Nairobi. That is Steve van de Vijver. Let's talk about some of these non-communicable diseases after this short break. This is Good Morning Kenya. Stay tuned.
KBC Channel 1, Kenya's watching.
Mami, kiatu inanifinya.
Mom, I've told you before, I've grown.
Huh?
Hii kitu imeshiriki tena.
Okay.
Download app ya OLX, piga picha ya ile kitu unauza, alafu uzipost upate chapaa sasa.
Hiyo ni ambadhi.
Exactly.
Sell it.
Okay.
Watu wote wanauza kwa OLX. Jiunge na Wakenya wengine kwenye celebration. We've got game.
Naonekana umejawa na furaha. Kwani bibi yako amepata mimba?
Wacha kunitania Titus.
Wacha nianzie mwisho badala ya mwanzo. Mimi na Bora tumeachana.
Mmeachana? Kwa nini?
Hatuwezi kuwa na uhusiano wa mapenzi baina ya watu watatu.
Umekuja nini? Huoni tuko katika hali ya kuwapokea wageni?
Kisa na maana.
Uliza swali ambalo jibu lake walijua.
Itabidi umeanza kuniongelesha vizuri na tuwe marafiki. Maana nitakuwa nakuja hapa mara mingi sana.
Sina haja ya kuwa na rafiki na wewe. Chunga kazi yako na mimi nichunge yangu. Makavazi.
As a president of Kenya Football, I want to urge all the Kenyans to watch KBC Channel 1 free of charge. They will watch all the matches, the 64 matches from the 12th of June. So it's another excitement, and it will be one of the most interesting World Cups ever. And I think Kenyans and the whole world will enjoy the matches. Watch KBC Channel 1, we have got the game.
KBC Channel 1, Kenya's watching.
Glad you're still watching. Good morning, Kenya. Welcome to part 2 of this program, where this morning we're talking about matters hypertension and other non-communicable diseases. And with me in studio is Dr. Steve van de Vijver. all the way from Netherlands, but he is a senior researcher at African Population and Health Research Center here in Nairobi, where he has been working for close to 3 years now. And we are talking about matters hypertension and non-communicable diseases, and what you need to do to ensure you keep those particular diseases at bay. Welcome to part 2 of the program, Dr. Steve.
Thanks, Martin.
So we've talked about hypertension at length, and now let's turn our focus to non-communicable diseases. When you talk about non-communicable diseases, what kind of diseases are we talking about here?
Non-communicable diseases is a very big group of diseases, but in general the World Health Organization and also other organizations try to focus on 4 key non-communicable diseases, which is cardiovascular diseases, diabetes, chronic lung and respiratory diseases, and the cancers. So these 4 contain the biggest bulk of non-communicable diseases. Then you have, of course, lots of other diseases like epilepsy and other elements, but they are involved in when you talk about non-communicable diseases, but they are outside these 4 key elements of the NCDs, or the non-communicable diseases.
Let's talk about, start by cardiovascular disease, because it's becoming a problem in this country and I believe the world over. Let's start by the causes of cardiovascular disease.
Yeah. Cardiovascular disease is also a big concept, a container, because what is cardiovascular disease? It contains heart attacks, heart failure, strokes, so it's also a bigger group. And if you look at the risk factors of developing strokes or a heart attack or heart failure, we actually come back also to hypertension, which is the biggest risk factor, but also, for example, obesity is a main risk factor. Then also all the other lifestyle elements, smoking, poor diet, reduced physical activity, these are also risk factors of developing cardiovascular diseases.
When you talk about all the particular problems that face the issue of cardiovascular, because I don't know what your research of late is showing, but there's growing concern of the number of people who continue to succumb to cardiovascular diseases, especially where someone just collapses and passes on. What is not happening when it comes to cardiovascular diseases, especially from where you sit as a medical doctor?
Yeah, I think what the problem with cardiovascular diseases is that we only think about it once we're in the stage of a cardiovascular disease, once we have suffered a stroke. And once you suffered a stroke, there's not much to do. I mean, your paralysis will be there, and you can take as much medication as you want, but you cannot reverse that. So the main thing of cardiovascular diseases is to try to address that in an earlier stage. So for example, by measuring your blood pressure. So really be there in front of that. And the problem is that sometimes this stage is there without you having complaints. And that makes it...
That's the initial stage.
Exactly. And that makes it very hard. So for example, with let's say HIV, you become sick and you really get complaints as well. Then you take your medication, your ARV, and you really start to feel better, and you sometimes really can reverse. With cardiovascular disease, it's different. And that even one thing is, you don't see a lot of people now dying or being sick of cardiovascular disease. Yes, that will happen in 10 more years. But with HIV, we really saw it on the street, and it really caught our attention, like we have to do something about it. With cardiovascular disease, this will happen in 5 to 10 years' time. It's happening now already, but the big chunk of people will only increase. So we don't see it right now, although it's starting, like I said. If you now really already start asking in families and friends, most people know someone with cardiovascular disease, but it's not as abundant as it was with HIV. But nevertheless, you still should now take precautions for that. Because once you're in the stage of cardiovascular diseases, once you have a stroke or you had a heart attack, it's too late. Of course, then you still have to focus on treatment of cardiovascular disease, so treatment of a heart attack, treatment of a stroke. But most of the time, lots of irreversible damage has already taken place. So the whole issue is to take it like to an earlier stage, treat hypertension, live a healthy lifestyle, stop smoking, and I think one of the main elements to try to bring this like now to the current situation is through policies. So policies, for example, on stop smoking, policy of prohibition of propaganda of alcohol in all kind of different settings. So there's lots of policies that now should be implemented in the country. And that's not just the Ministry of Health. I think what is most of the time have been said at conferences, every minister is a health minister. So in every ministry there's health involved. So if you are the Ministry of, let's say, infrastructure, and you think about roads and traffic, it's very important to also think about how people can use public transport and also can walk or cycle. And that's not, for example, for Kenya, it's not a very strange thing like that's what happened in 20, 25 years. I mean, countries and cities have done it. For example, in Bogota, in Colombia and South America, there was a very progressive mayor, and he really changed the infrastructure and made sure that buses were driving there, that people could walk, could cycle, and that has a tremendous impact on health and cardiovascular diseases. And that's actually coming from an infrastructure perspective. And you have the same with the Ministry of Finance, this Ministry of, well, every ministry in a way is related to health. So I think the best thing would be if on a policy level, all ministries would be informed to try to mitigate the risk of developing this enormous epidemic of NCDs and specifically cardiovascular disease by having a focus on that and try to think about all the implementation elements. How is this going to influence health? And even better, how will this benefit health? And how will this prevent from chronic diseases?
And so, can we then say we have got stages of cardiovascular diseases, and at which stage should one say, I must take precaution before things escalate?
Yeah, I think lifestyle is something everyone should pick up. But I think the moment you talk about where you really get beyond the barrier and you should think about treatment is, for example, when you develop hypertension. That's the moment you really get close to developing cardiovascular disease. And developing hypertension means most of the times that you have to take medication. And this medication, most of the times it's a pill or two for once or twice a day. And the issue is you have to take it for the rest of your life. And that's a complicated issue. That's very
challenging. You take it for the rest of your life.
Yeah. And I think there's where, in Kenya and in this continent, there is a need for like a paradigm shift to start thinking more in managing your health instead of getting treatment, go to the doctor, get cured and go back to work again. Because it's not a one-off interaction with a nurse or clinician. It's an ongoing interaction to manage your health in order to prevent you to develop cardiovascular diseases. So it's important that people come back and are transparent and say, well, this medication, I had a bit of side effect, can I use something else? And then with interaction with the medical doctor, you try to find a pattern and a lifestyle and some medication that really would benefit you and prevent cardiovascular diseases. And it's not that if you say, well, this pill, I don't feel any better, because as we discussed earlier already, most people with hypertension, they don't have complaints. They only know that they have high blood pressure because they've measured it. So it's hard to convince people that to take medication, although you don't feel better right now or tomorrow. The thing is, you take that in order to prevent this cardiovascular event, which comes up maybe in 5 years' time.
You talk about stopping smoking being a key issue and being a key remedy to this. You talk about alcohol, but I know so many people who don't smoke, they don't take alcohol, but more often than not you hear somebody has passed on because of cardiovascular disease.
Yes.
What might be the reason behind that?
It's when we talk about risk factors, it doesn't necessarily mean that you have to have these risk factors to develop cardiovascular disease. Like you say, indeed, you can get cardiovascular diseases without smoking and living a healthy life. Maybe you are genetically prone. And also I think cardiovascular disease in general, it's really now picking up, and we do have to do lots of research in all causes and ideas around this. When do you develop cardiovascular disease? So hopefully in the next 10-15 years, we will also discover more elements that are involved in this to develop cardiovascular disease. But for now, the evidence shows that at least we know that with smoking, diet, good physical activity, and limited alcohol use, you can reduce cardiovascular diseases. So that is it for now, but it doesn't say that still people might develop cardiovascular diseases while living a healthy life. Sometimes it's, like I said, it's in some families, you see there's a much higher risk of developing cardiovascular diseases. When you know that it really runs in your family, it's a very strong motivation to actually go to the clinic and measure your blood pressure. So at least try to do as much as possible to mitigate the risk.
How expensive or cheap, as it were, is it to treat cardiovascular disease? Because one might cite that as an entrance. Say, I know I have the disease, but the expenses are just so high for me to manage it.
Well, it's a very good question, Mark, because cost indeed is a very important issue. But luckily, as I said, cardiovascular disease is already a big problem, has it been for a long time in Europe, in China, and the rest of the world. So now there are lots of medication, and they are most of the times they're generic medication, which means actually that they're very cheap. So for example, with the scale-up project we're doing in Korogocho, we can offer people medication for 100, 150 shilling a month. Then you get your medication for hypertension. I mean, I understand 150 shilling is still something if you can decide between having that or maybe having a beer or something else. It is a step, but most people can afford it. And so it's luckily not as difficult, for example, with diabetes, where you might need in a stage insulin, which is very expensive. But for hypertension, medication is relatively cheap. I think the main challenge for medication is the availability of medication in clinics, because that's something that we're also talking about with the Ministry of Health. In order to really address this epidemic, it's essential that every clinic, even the smallest dispensary, has medication for hypertension. And that's currently, unfortunately, not yet the case. It's still seen as something that might be treated in a district hospital or somewhere else. Whereas, for example, in the Netherlands, but also in China and other settings, hypertension is a relatively simple disease situation that can be managed by nurses or clinicians. You don't need a doctor to treat that. So I think there are lots of opportunities to really try to decentralize that and empower and train clinics and make medication available in these settings. And these are not high cost.
Not high cost, but you talk about diabetes. How prevalent is, in fact, what is diabetes, and then how prevalent is it across the world and in Kenya, for example?
Well, diabetes is actually a disease where you have problems to regulate the level of glucose in your blood. Actually, glucose is like when you have lots of increase of sugar, it gets into your body, you make glucose, and that has to be regulated. When your body cannot cope with that, that's diabetes. And diabetes has two forms: diabetes 1, which is more happening in children, and diabetes 2, which is more happening in older people, like lifestyle diabetes. And you see now mainly a growth in the second group of people developing diabetes because of obesity as well, and because of lifestyle. And currently, the prevalence in Kenya is around 5%. And that's, like I said, genetically, Africans are more prone to develop hypertension than diabetes. But if you look in a global perspective, diabetes is increasing very rapidly as well. So specifically in the Indian and Asian population, you have areas where 10, 15, 20% of people are suffering from diabetes. And the same, for example, in the Middle East, in Kuwait, in the Arab Emirates, you've got big problems with diabetes. And also in the continent, but more if you look towards Egypt, there's a big problem of diabetes.
The question will be, why will children be vulnerable to diabetes, especially diabetes one that you're talking about? Because you don't expect a child to really take high levels of, say, glucose or sugar, as it were. Why the prevalence in children as well?
Well, diabetes 1 has not much to do with lifestyle. It's like a disease that actually the pancreas, which is the organ which is responsible for regulating your glucose levels, is actually dysfunctioning. And to say that's more bad luck. It doesn't say that this little child has lived an unhealthy life, yes or no. It's just some children get that and others don't. It's just diabetes 2, which has a very strong relationship with lifestyle.
Diabetes 1, what causes the dysfunction of the pancreas in children?
Well, it's quite a technical story, but we're still doing lots of research on that, but it's most of the times also thinking as a reaction of the body, like an autoimmune thing. And most of the time it's happening spontaneously. It's not an infectious element or anything, but it's a reaction from your own body to actually stop working.
And when you talk about diabetes too, you talk about lifestyle. What are these things that adults do that make them become susceptible to diabetes too?
Yeah. Well, what do adults do? Adults love to just sit on the bench, watch a movie, have some chips next to it.
Or a soap.
Have a soda. And that actually, if you do it in a limited amount, it's okay. But if you do that for the whole day, then you might get diabetes. So what you see is actually that the lack of exercise and the increase of fats and sugars, specifically those two last things, have really an impact on diabetes. So you see that drinking a Coke or soda or anything really influences your risks of developing diabetes in later stage. Because people forget how many scoops of sugar
are in those liquids, for example.
Yeah.
Is it the reason why you will get some people telling you, listen, if you want to use fats in liquid form and not in solid form?
Well, for fats, there are all kind of different fats, and it's almost, we can talk for an hour about just the different fats and what you can do about it. But I think the main thing is, and that's also for the sugars, that I'm not saying you should like completely stop, but you should really limit it, because in a modern lifestyle, it's hard to completely exclude fat and sugars, because most of the times we don't even know in which products is actually fat or sugar. So for example, if you take, let's say, milk, most of the times, I mean, I don't know the Kenyan milks, but the milks in the US and Europe contains sugar, for example. You wouldn't think about that. And also if you look at bread, that contains a lot of salt. And these kind of things we are not aware of. So I think it's important to at least not add extra sugar or salt to your daily diet, because it contains already a lot. So if you take, for example, if you eat a pizza, then you have already sufficient salt for the whole day. You shouldn't add any salt on any product, because that's it. You've reached the limit. And I think that now more and more people will hopefully start to understand which ingredients are in every product. And if you talk about policy making, that's now, the UK is quite advanced in that you actually have in every product in the supermarket, you have like a traffic light, and it says how much salt, sugar and fat it has, and whether it's healthy or not. So when you see all kind of red lights, it's like, is this actually healthy? So it stimulates people to actually look at the package and look at the ingredients and don't look at fancy colors and discounts, because that's of course what the commercial interests are of supermarkets and other producers of food. But I think it's important as Kenyan population and citizens and every individual in this country to take the responsibility and really try to look at the package, what's in it. And it's a responsibility from the policy makers to actually really regulate that people are putting that on every package, and that this is going to be a law.
And I've seen a number of people, especially the adults also, who say, while taking tea, for example, I don't put any sugar. Does that also help in regulation of
yeah, definitely.
diabetes?
Yeah, and I think that there are small steps, and I think that is a very good step to actually try to reduce or stop taking sugar in your tea. And I know Kenyans, they love sugar.
Sweet things.
They love sweet things, they love nyama choma, they love salty things. And I'm not, like I said, I don't say you all have to be very rigid to it, because I also think it's important to enjoy life. But at the same time, there are very good ways to enjoy life in a healthy way.
So that if possible, avoid nyama choma.
Well, it's very dangerous, I think, as a Dutch medical doctor to say to avoid nyama choma in this country. I mean, I will get issues, I would say. But like I said, I mean, you can have nyama choma if you have something to celebrate. I would definitely support it. And actually, to be honest, I love nyama choma myself as well. But I think it becomes a risk when you have nyama choma 2 or 3 times a week. Then you have to start thinking on how can I adapt other elements to live a healthy life.
You know, the problem with some of these things, they're so sweet that to avoid them becomes a problem. Let's talk about cancer. I know my time is almost up, but cancer is also becoming another dangerous disease. Steve Jobs succumbed to it. In Kenya, Professor Ngari Maathai, and a number of leaders and even ordinary Kenyans who continue to succumb to cancer. What is the latest statistics in terms of cancer, and which one is becoming more dangerous from where you are?
Yeah. Well, cancer is also, like cardiovascular disease, it's a big group in itself. So you have, for example, breast cancer, lung cancer, colon cancer, cervical cancer. So there are several cancers which form an important group. But I think it's important to focus on a few cancers that really can be reduced quite drastically. And I think, for example, cervical cancer is something which was a big problem also in the West. But through screening and vaccination, you can really reduce that. Young women should have regular checkups of their cervix to try to reduce the risk of develop cervical cancer. Lung cancer, for example, is also quite easily to prevent by just stop smoking. And I think for all these cancer groups, the main element is the same as with cardiovascular diseases. Don't think about treatment, but think about prevention. Because once you move to treatment, if you have lung cancer, you can get treatment, but chances are that you still will die. So you actually are there too late. And that's not just on the life and health perspective, but also on the cost perspective. So the Ministry of Health should be much more focusing on money and efforts on the prevention, exactly. And it's interesting that these 4 non-communicable diseases, and specifically cancer as well, you have 4 risk factors which play an important role in developing cancers. And that's, again, stop smoking, reduce alcohol, have physical exercise, and improve your diet. So also for the cancers, these 4 elements have an important role in that.
Steve, I think I'm just going to invite you for part 2 of this discussion so that we look at the other non-communicable diseases, because I know we cannot exploit all these particular diseases for now, but 16 days to go and we'll be heading to Brazil.
Yes.
Are you so much expectant?
Yes. Yeah, I'm really looking forward to it. Yeah. And well, I think it's going to be a a very great addition. And well, of course, I support the Dutch team.
Because you come from Netherlands.
Yeah, I come from the Netherlands. Yeah.
So Robin van Persie and the group.
Van Persie, Robin, we've got a few good strikers, but I think we have to arrange a bit the midfield and the defense. But I hope we play at least attractive football. I don't aim that we would win, but at least we should hopefully go back to the Dutch way of playing soccer and football and really enjoy the audience.
And of course, by now, you know, KBC Channel 1 will be exclusively broadcasting those particular games. What will be a message to Kenyans even as we wait for the 16 days and showcase this particular competition?
Well, I think the next 16 days really try to get to know what is the schedule of the matches, who are the players, the teams that are there, and I would definitely advise people to watch the games on KBC. Sometimes you have to get very early in the morning, you have to get out of bed or you have to stay awake, but I think it won't disappoint you.
Steve, thank you very much for getting time to be with us.
Perfect.
And I can assure you, part 2 of this is necessary. We will be inviting you again.
Perfect.
So that we discuss about this. Steve van de Vijver, he's from Noordrong, a medical doctor from Netherlands, and he works with African Population and Health Research Center, talking about hypertension and other non-communicable diseases. My name has been and remains Martin Mwanja on behalf of the entire technical and production crew who made this production a success. Another and a lot of programming is still lined up for you. You stay tuned to KBC Channel 1 because this is a station where Kenya is watching. Let's do this again tomorrow, God willing. Bye-bye.
Thanks.
Thanks.